Thank you very much, Mr. Chairman, for that kind introduction. And indeed, I'm going to talk about survival after resection of multiple tumor foci of intrahepatic cholangiocarcinoma. Intrahepatic cholangiocarcinoma, as you no doubt know, is a very rare malignancy occurring in the peripheral bile ducts of the liver. It has an annual incidence of 1 to 2 cases per 100,000 people, and it's associated with grave outcomes. The only curative treatment for intrahepatic cholangiocarcinoma at the moment is resection, and this tumor, especially with multiple foci, requires large, extensive operations and carries a high perioperative risk, as is illustrated in this study by Wiggers and colleagues. In patients with a small future liver remnant, in-hospital mortality can be up to 30%. So it's very important to select the right patients for these procedures. And in the current guidelines and in the AJCC 7th and 8th edition, intrahepatic metastases or multiple tumor foci should be considered a relatively strong contraindication to surgery. So therefore our aim was to define long-term outcomes in patients with multiple tumor foci in a large multi-center retrospective database. In order to do this, we included patients from 1990 to 2015 from 12 centers all over the world, and we only included resected patients. So we analyzed using the normal methods, and we also made a multivariable Cox model. So first answer the question, is it safe to resect these patients? As you can see here, these are the short-term perioperative results, and there is no significant difference between patients treated for a single tumor in the liver and multiple tumors in the liver. We also looked at oligometastasis, here defined as a single extrahepatic metastasis. And in this table, you can see that for these patients, perioperative results were significantly worse than for patients treated with a single tumor only. As can be seen from this Kaplan-Meier plot, long-term survival is possible after resection for multiple tumor foci in the liver. As you can see, 2 lesions carry a 5-year survival prognosis of about 25%. And more than 2 lesions, a prognosis of about 10% for 5 years. For extrahepatic oligometastases, this is quite severely worse. The 5-year survival is 10% for these as well. So we performed a multivariable analysis of these patients, and as you can see in this table, oligometastasis did not reach significance in our multivariable analysis, but it's closely related to some of the other factors included here. As you can also see, 2 lesions did not infer a more severe prognosis than a single lesion, and more than 2 lesions did have a significant effect on prognosis with a hazard ratio of 1.94, which was very significant. So concluding, we have confirmed in this series that the procedure of resection of multiple tumor foci is significantly associated with it has a significant morbidity, but for multiple tumor foci in the liver, this is not necessarily more riskful than for single liver tumors. The uncorrected 5-year survival for multiple tumor foci in the liver was 27.8 and 9%, which is reasonable considering that this is the patient's only chance of curation. And of course, this study has the bias inherent to all retrospective studies that there is a large selection of patients. And we would like to conclude that maybe multifocal ICC should not always be a contraindication for surgery. Thank you very much.
Thank you for this very nice study with huge number of patients. I just have a quick question. As you know, there are 3 types of intrahepatic cholangiocarcinoma: the mass forming time, the one with periductal extension, and the one with intraductal extension. Did you include that in your analysis? Because we know that Those three factors have different outcome.
They have different outcomes. For the purpose of this presentation, we all pooled them, but we do have information on mass forming versus periductal infiltrating type. And for the final study, we will certainly include that in the analysis. The huge majority of cases in this cohort is intrahepatic mass forming in the peripheral bile ducts.
Go ahead.
Time for a quick question. Jason Denbo, Minnesota, USA. The question is, how can you more clearly define these secondary lesions or these other intrahepatic metastases? Were these in the same segment? Were these in the same hemiliver, the opposite side of the liver?
Right.
Can you clarify that?
Yeah, thank you for that question. It's considering this is a retrospective database, we not always have all information on all patients, but we chose to look at the number of lesions rather than, for example, satellite lesions or the distinction between satellite lesions and intrahepatic metastases, because those definitions are not always clearly defined. So we purely looked at the number of tumors in this study, and as I said, there is a certain selection bias in that at the time the surgeon thought that this patient was eligible for resection. So yes, but this selection bias can be reproduced, and so we still think that these results do contain value for that these are valuable results.
Yeah, okay. Any other questions? Just a quick one, please.
Hi, Sture on Stockholm. I was wondering, did you also have any records about adjuvant chemotherapy in these patients?
Yes, we do have records on adjuvant chemotherapy. For this multivariable analysis, we chose to look at the disease-related factors. I think from the top of my head that about 1/3 of the patients had different kinds of adjuvant chemotherapy. Since this study spends more than includes patients from over a decade of experience, these chemotherapy regimens changed over time, but we'll definitely look into that for the final analysis. Thank you very much.